the February 5th meeting of the Health Policy Commission to order. Welcome you to the first commission meeting of 2020.
We can talk later. Okay.
I also want to welcome our chair, Stuart Altman, who is with us via teleconference. And Stuart, on behalf of all of my fellow commissioners, welcome back. We're so happy that your health is better and that you could join us, at least for now, by teleconference and hopefully in person at our future meetings.
That's great. Looking forward to it, and I'm sorry I'm not there today, but there were just too many conflicts. But I'm feeling much better, thanks, and I appreciate all the nice statements and visits from many of you, so thank you so much.
Great. So just to review the meeting today, we have a report from the Market Oversight and Transparency Committee, notices of material change. We have the 2019 Annual Cost Trends Report, findings and policy recommendations. And then we have action on our drug pricing review, final regulations. We'll follow that with an executive director's report, and then we will be going into executive session to review performance improvement plans based on the latest data that was made available to us by CHIA. We will not be reconvening in public session after the executive session. So just to let people know, our next meeting will be on March 11th, 2020. That will be our annual benchmark public hearing done with the Joint Committee on Healthcare Finance, and that will be at the Gardner Auditorium in the State House. That notice is posted on the Commission's website. To start things off, we will do a approval of the minutes of November 20th, 2019. Can I have a motion to approve the minutes?
So moved.
Second. Second. Are there any additions, deletions, changes to the minutes? Hearing none. All those in favor? No, we're going to do this by, since Stuart wasn't at the meeting, we'll do this by just vote. Vote, and then we'll do roll call for future. Okay.
It's okay.
All right. We will do a roll call vote. So, Cassandra.
Aye.
Abstain. I wasn't at the meeting.
Aye.
Aye. Aye. Aye. Okay. The minutes of November 20th are approved. We will now go into the notice of material change. David.
Great. Good morning, commissioners, and welcome, Stuart. So great to have you here participating in this meeting today. As Vice Chair Cohen said, we have a full agenda today with two pretty significant pieces of work to move forward. And so I think let's just dive right in. So I'm going to turn it over to Megan to give our regular update on material change notices.
Thank you, David. Since 2013, the Health Policy Commission has received notice of 107 provider transactions, with physician affiliations and clinical affiliations the most frequent, followed closely by hospital affiliations. The HPC has one notice currently under review, the proposed merger of two federally qualified health centers, East Boston Neighborhood Health Center and South End Community Health Center. We have not received any new notices of material change since our last board meeting. Since the last board meeting, we elected not to proceed to a CMIR for two transactions, a joint venture between Bay State and Greater Springfield Surgery Center, an ambulatory surgery center in Springfield, and Partners' proposed acquisition of Exeter Health Resources in New Hampshire. For both transactions, our analysis suggested limited scope for increases in spending in Massachusetts. We did not review evidence suggesting negative impacts on quality or access to care in Massachusetts. The HPC understands that Partners' proposed acquisition of Exeter Health Resources is still under review by state and federal antitrust agencies.
Any questions for Megan?
Yes. I don't remember the stats. Since we started doing this, have the number of transactions increased annually? Has it remained fairly constant? Can you answer that?
I haven't looked at that in a couple of years, but in general, it's remained fairly constant. I'd be happy to get that stat for you
Yep.
after the meeting.
Is this the first transaction we've seen of, that's been brought here relating to health centers?
Yes, it is.
I thought we were deferring on that one.
It is still under review and will continue to be under review.
Any other questions? If not,
Thank you.
we can move to the second part, which is the cost trends.
Great. So thank you. We're going to switch topics and move into our first main agenda item today, which is the 2019 Healthcare Cost Trends Report. First, I just want to thank commissioners and stakeholders for their feedback into this publication. This is, really a year-long project to put this report together, and becomes, I think, a signature publication for the Health Policy Commission, and helps set our agenda and our priorities for the next year. And so, looking forward to engaging with you today on really where we go next with this work. Having completed the report and hopefully issuing it today, where can we continue to advance our research and examinations of trends in the healthcare marketplace, and where should the Health Policy Commission, along with other state agencies and actors, work together to advance some of the recommendations that we're proposing today. I would note at the outset that the level of sophistication and expertise that goes into the claims analysis and data analysis of the research team here at the Health Policy Commission has really grown every single year, and this report, I think, reflects a really sophisticated look and examination that, candidly, I think no other state is doing. So it is really a testament to Massachusetts, to other state agencies, and I want to give a special shout out to the Center for Health Information and Analysis. Without them and the data that they collect, this work would not be possible. But also a great reflection of cross-agency collaboration with Mass Health, the Department of Public Health, the Division of Insurance, and the Connector, as well as the Betsy Lehman Center that we relied on for some advice on some of our work, especially around sepsis and septicemia. So for today's presentation, we do have select findings that we are going to present. I would note for the commissioners, all of these findings have been presented at either a board meeting or a committee meeting, or either in September, the cost trends hearings at November, or January. But not all commissioners are at all the board meetings or all at the committee meetings. So did want to just take this opportunity to just hit some of the highlights one last time, and then move into a conversation around the recommendations. And so with that, I'm going to turn it.
No, I was just going to ask you a question.
Sure.
In light of our full agenda for today, what's your ideal as to how long when we would want ideally wrap up the discussion of the cost trends report?
I think we have a good 45 minutes for this topic, and then we
Just
can.
so we can judge ourselves how we're doing.
Yep. And certainly, I've asked David to move rather expeditiously through the findings, but obviously, please pause and ask questions along the way. Some of it is just kind of foundational for the recommendations conversation. So with that, I'm going to turn it over to our Director of Research and Cost Trends to first give an outline of the report and then walk through some of our key findings in the different chapter areas.
Great. Thank you, David. Okay, so the main report has 4 major sections and then the chart pack. The first section, an overview of trends in spending and affordability. Then we focus and do a couple of deep dives in the hospital. First, inpatient and then outpatient trends, and then policy recommendations, which we'll present here today afterwards for the first time. And then the chart pack, which accompanies the report, has several subsections as well, including provider organization performance variation, which we've talked about in the past, but now it's in the chart pack this time. Hospitalization, post-acute care, alternative payment methods. So I'll show several highlights from each of these subsections with a cover page just with text bullets of some of the key findings. Okay, so for the first section on the overview of trends in spending, as we know, we met the benchmark exactly this year, 3.1% growth in total healthcare spending from 2017 to 18. But there are a number of challenges and trends of concern that we describe in the chapter. On the commercial side, for example, spending per person, when you include the admin costs, was above that. It was about 4.6% spending growth per person enrolled. And high deductible plans, for example, are now covering about a third of commercially insured residents. And that continues to rise each year. And that is related to an increase in cost sharing, what people pay out of pocket, of 5.6% last year. Family premiums grew, in addition to the out-of-pocket, those premiums grew 15% over the last 2 years combined, 2016 to 18. And when we add all this together and look at how much income grew for families in the last 2 years, we find that the sum total of all healthcare spending absorbed about 39% of all income growth over those 2 years. And we have a graphic to illustrate that I'll show again. So the next slide goes over the performance over the last 6 years compared to the benchmark, and you can see that there's a 3.1%, which is now the target, and we met that in the last year. Average growth over the full period of 6 combined years now is 3.4% growth. This slide shows, separated by market segment, growth per enrollee and the change in the number of enrollees. So you can see in the blue, there's that commercial 4.6% growth that I noted. Growth per enrollee was a bit lower, below the benchmark in Mass Health. In Medicare fee-for-service, it was also above the benchmark rate. And there were some difference in enrollment by sector that also drive some of the spending totals. That's in the yellow bars. Okay. And finally, as I noted, growth in healthcare spending as a percentage of total growth in income. You can see in that orange section, this is the division of $1 of income gain from 2016 to 18. And that orange section was greater than all the amount that people had to take home after taxes to spend on everything else. Okay. So our next deep dive is on the hospital inpatient side. Especially in the commercial sector where we focus most of the effort, but sometimes we're looking at all payers as well. For commercial patients, as we've shown, over the last 5 years, hospital inpatient spending grew while volume dropped at the same time. And we dug into this trend on both sides. Why did spending grow? Why did volume drop? And we found that the volume drop was due pretty much equally to declining birth rates, which reduced maternity-related admissions, and fewer scheduled admissions, some of which are shifting to the outpatient side, which we'll get to. On the spending side, we find that the spending growth was roughly equally divided into price increases and increases in the acuity of hospitalized patients, which leads to higher spending. And when we dug more into why that acuity was rising, we don't find any evidence that it was due to actually sicker patients, but it appears to be mostly due to changes in documentation and coding practices. Now, we'll note that this isn't fraudulent. It's not unique to Massachusetts. It's happening everywhere. It's a practice. And there can be some benefits to that more complete documentation of patient illnesses, but it does lead to millions in additional spending. And that's something that we are tracking and that is concerned. And it also can interfere with accurate performance measurement, where performance is often measured conditional on the health status of those patients. So risk adjustment, it gets in the way of proper risk adjustment. And on the volume side, again, on that trend of shifting to the outpatient setting, I'll get into this a little bit, but it generally should be saving money, but we find that those shifts are not occurring uniformly across hospitals. Shifts are moving towards higher cost hospitals, which is eroding the savings that we might otherwise expect. Okay, so here's that trend of the rising payments and the declining volume on the commercial inpatient side. Overall, what it means is the average spending per admission grew 5.2% each year from 2013 to 2018, or 29% total growth over that time period. Okay, and this is illustrating that growth in acuity. Here, not just looking at the hospital inpatient side, but the full patient's experience over the course of a year, which is described by your risk score. And the growth is the same. It's pretty much the same trend we see on the inpatient side, of about 12% growth in risk scores over these 5 years. And when we investigate whether this is due to population aging or a greater chronic disease burden, we don't see evidence for those at all. And this slide illustrates, back to the hospital, that growth in acuity of hospital patients. This is an example of COPD where admissions are coded at one of 4 severity levels, and you can see on the right there's a higher payment attached to each level of severity. The highest severity is the blue. And you can see in the trend to the left, there is just a gradual pattern of more and more severe patients being coded with COPD. And the payment implications there are pretty obvious. Okay. And we don't find any evidence for actually worse health of these patients. Again, a slide about the inpatient decline in volume, showing that most of it was due to the maternity and the scheduled admissions on top. And on the topic of shifting from inpatient to outpatient, we did a deeper dive into a number of conditions where this is occurring, and we find that there is indeed, when you look in the APCD, you can track these cases on both the inpatient and outpatient side. And you see for spinal fusion, mastectomy, hysterectomy, that the proportion being treated on the inpatient side in the dark blue is declining from 15 to 17. The outpatient side is the light blue for each of these, and they're pretty dramatic in some cases. Okay. So then we move to the outpatient side in the next chapter, and here are some highlights of the trends there. First, just to note off the bat that in the realm of commercial hospital spending, more of it is outpatient than inpatient. About 60% of it is outpatient. And when we try to analyze that, we focus on surgery, which accounts for 1/3 of that spending. And we then subdivide surgery further into major surgeries and minor surgeries, and we go into this in the report. In terms of what is driving the spending growth in outpatient surgery, it's mostly prices, it's mostly payments per episode, and I'll show that in a minute. We also find that the volume of surgery is highly concentrated in higher cost, higher paid hospitals, and those price variations are pretty extreme, and I'll show that as well. And overall, on this shifting story, again, shifting from almost anything from inpatient to outpatient will save money if it's within the same hospital, but we see trends of shifting across hospitals, which are diluting those savings. This summarizes the surgery findings. Major surgery on the left, which is things like knee repair and hysterectomy. Minor surgeries on the right, things like colonoscopy with biopsy. And the stories are different. They both grew in spending, but for the major surgeries, the growth was driven by payments per episode, not by volume. For the minor surgeries, the growth was driven by more volume. So we go into those in the report, but it is an interesting trend. Okay. And this slide illustrates price variation for some of the major surgeries we looked at. And in each case, we're showing the 6 highest volume hospitals and just the average payment for episodes. And they're pretty much all the same. The intensity of these episodes are similar in almost all cases. And we see that the partners hospitals tend to be an outlier, sometimes as much as twice as high as the lowest price high volume hospital. Okay. And finally, an illustration of an example of where this shifting from inpatient to outpatient would save us money, but not if they're shifting across hospitals. We're showing a high volume community hospital on the left. These are average payments for a hysterectomy on both the inpatient side in the dark blue and the outpatient in the light blue. and a high volume AMC on the right. You can see for both, treating the case on the outpatient side is cheaper. But what's happening is the net volume, the volume is dropping in the community hospital and the volume is growing on the AMC. That is, the community hospital is losing more on the inpatient side, 21, than is gaining back on the outpatient side, while the reverse is true for the AMC. And that AMC price is so high that its outpatient price is above the community hospital's inpatient price. And so that's actually an increase if there is a net shift in that direction. Okay. So then we move into the chart pack, which is some of the trends that we have been tracking year after year. One high point that has been true for the last several years is that after a hospitalization, there are fewer and fewer patients going to institutional post-acute care, such as a skilled nursing facility, and more to home health. On the other side, we see continued decline in alternative payment model use. In the commercial market, over the course of 16 to 18, it dropped again, and overall from about 45% to 42.8%. And readmissions continue to not improve and diverge from the US trend. This is a little more detail on the APMs. And in this graph, you can see that for the big three payers on the left, Blue Cross, Harvard Pilgrim, and Tufts, and you see their PPO populations in blue and their HMO in orange, that their use of APMs is growing slightly over the 3-year trend. So the reason that we're declining overall is not for those payers, but it's for the other mass payers, where APM use is dropping, as you can see, and for the national insurers, which don't use them to any appreciable amount in the state. This is the readmissions trend, which we've shown and talked about. The divergence in our Medicare numbers from the rest of the country is in the dark blue and the light blue. And for the topic of provider organization performance variation, we cover a few subtopics in this piece of the chart pack. Overall spending, we see a pretty big variance in spending for patients based on where their primary care physicians are, with the highest being Partners and the lowest being Atrius, a difference of about $1,500 per year, or 1/3. We see a big variation in avoidable ED visits by provider org, and we also look at low-value care, and we see a considerable amount of low-value care continuing to take place. This is the trend in overall spending, as we've seen. We're showing both unadjusted spending and risk-adjusted spending, and the patterns are pretty similar. Here's the trend for all ED visits and for avoidable ED visits, which are the dark blue. And there's a difference of more than double on the avoidable ED side, with BMC and UMass higher, Atrius and South Shore on the low end of this. Okay, and low value care spending. We show a number of individual measures of low value care, such as preoperative testing that's not necessary or vitamin D testing. This summarizes all of those measures into just a total spend on low value care per attributed member. And you can see about 2-to-1 variation. Oops, I didn't show the slide. From the top to bottom. Okay. So that is a quick tour through the results. I didn't even get the David Cutler pinwheel, so I think we did okay. All right, David.
I was barely keeping up.
That was the idea.
So we went through that quickly, but I think, as said, these are slides and findings that I think are familiar to you at this point. Happy to open it up for some conversation now, where we can move directly into recommendations, and seeing the symbol, I think we will. An important part of this report, as always, is our policy recommendations. And I know that every one of the commissioners here has had an opportunity already to review these and provide input to them, but do want to have an opportunity here with all of you together to be able to discuss your own priorities and your input about how the HPC can best move these policy priorities forward. I will note at the beginning, and this is something that we've done for a few years now, the report contains both some new topical areas that are informed by the research and work of the HPC, not just in this report, but over the course really of the calendar year, as well as many revised and refreshed and renewed recommendations that have been a part of the HPC's reports in the past, and for which we think that continued action is necessary and needed. So many of those recommendations, I think, are very well familiar to this board, but I will take a few moments just to walk through some of the new topical areas and then open it up for some conversation. So first, I would note that the slides here represent basically an abridged version of each of these recommendations. In the report itself, each one of these goes into another level of detail and specificity. It would have been one recommendation per slide, so in the interest of trying to summarize, we did our best here, but encourage members of the audience and others to really go and look at the full text of these recommendations. So our first recommendation really is building off of the great presentation and work that we had at the cost trends hearings from Marie Ganem from Rhode Island and the Milbank Foundation, who talked about the importance of building and strengthening primary care as a foundational element to having a more efficient and a more equitable healthcare system. There is now growing and considerable evidence that health systems that are oriented towards primary care provide greater value and access to patients. This, of course, is fully consistent with the goals and principles that Governor Baker and Secretary Sutters have proposed in terms of making a statement that we should, over time, increase our investment in these important areas, not just primary care, but also behavioral health care, areas that have been, I think, widely recognized to be underinvested in historically and perhaps unprioritized by general healthcare market forces. The research does back up this initiative and this work, and we are recommending that policies should be put in place to try and increase the investment and expenditures in these areas, while still, I think importantly for our mission at the Health Policy Commission, maintaining and adhering to the overall healthcare cost growth benchmark. That there is opportunities for a redistribution over time of dollars without increasing the overall spending, leading to a more efficient system over time. Additionally, in the full text of this recommendation, we talk about the need to measure and to track what the proportion of healthcare spending is going to these areas now and in the future, and to perhaps set improvement targets accordingly. Additionally, in this recommendation, we have some specific strategies around improving access to both of these important areas of care. These are, I think, a little bit of repeats for the Commission, things around removing outdated scope of practice restrictions, such as on nurse practitioners, and also creating an environment where technology and telehealth and telemedicine can be used to enhance access to primary care and behavioral health care and other services. So kind of a two-part both investment and access recommendation here.
David, can I ask you one question relative to telehealth? Is there anything in particular that you're recommending that policymakers should do to support telehealth, or is it encouraging providers and insurers to use it?
We do think, and the recommendation does speak to an idea of having that payers should cover and pay for these types of services, and so that they should be consistent with their coverage for in-office visits or in-person visits. So there is a recommendation, and that is there is pending legislation that does speak to that issue in terms of ensuring coverage for these types of technologies.
You can support the governor's health care bill.
Okay, great.
Well, that was easy.
So, David, I understand the answer for telemedicine, and that sounds like something that can happen. What about specific recommendations for increasing spending in primary care? Or are we leaving that into a long comment period from providers and payers?
So the recommendation, as we've written it, is not specific in terms of a specific target or increase, percentage increase, and speaks more to a principle that we should put in place policies and structures that would measure, track, and perhaps set, and the recommendation talks about improvement goals in these areas. I think understanding that this is a signature part of the governor's bill and that there is a legislative process that will be debating exactly how that might happen, to what degree, and in what specific areas investments should be prioritized. I think our recommendation is perhaps a little bit broad and a little bit more in terms of supporting the value statement that we as a community should work to figure out how we could do this and how the best way to do this. So I think there, absolutely to your point, Dr. Kreider, I think more work to be done in terms of fine-tuning the specifics of that. And again, I think a little bit of a deference to the legislative process on that, given the governor's bill.
I raise it because there is data for successful coordination of care and reduction of admissions when you increase the reimbursement for comprehensive visits. So 99215s and or 99374, I think, for preventive care. So I would hope, and I don't know, that Medicaid is exploring that and looking at models around the country and even locally. I mean, we see the numbers for Atrius and much better than others, and while they may not be billing for those capitated patients, they create incentives for deep and long visits for coordination of care and corresponding reimbursement. So it seems like an easy one to me.
Yeah, and
all healthcare is easy.
But why couldn't Medicaid increase a 99215 reimbursement by 3x tomorrow?
Right, so Medicaid is very much a part of the governor's health care bill. For anyone who's read it, it is, so the governor's, so first of all, I very much appreciate this recommendation. It's certainly the cornerstone of the governor's health care bill, which for us, we sort of believe that, so we set the mark of 30% increase by both large providers and in payers, and the payers actually include Mass Health. So Mass Health is not actually eliminated from this requirement, and the restructuring of the ACOs is very much around care coordination and the creation of medical homes, and a number of these, including Atrius, is actually a Medicaid ACO provider. So I wouldn't say that we're not there, but we're not looking at individual claim codes. What we're really looking at is population health, and that's how we're paying the ACOs for their focus on primary care and care, as you say, care coordination, because it's time, a little bit less than technology.
Except for telehealth, which also,
Well, we
if
actually,
the
so
reimbursement
Medicaid,
is
so
good.
so Medicaid actually, we rolled out telehealth in the Medicaid program, and I think one of the challenges is that you need all payers sort of in the space in order for this to be successful, because it does require a certain amount of infrastructure within providers, right? So if it's only for, I mean, I'm happy to say it's only for Mass Health, but if it's Mass Health and commercial and Medicare, right, it really increases then the base.
Thank you, Madam Secretary. And Dr. Kreider, to your point, I was just looking at the exact text of the recommendation, the longer version, and we do talk about that payers and providers, so both entities, should increase spending, and parentheses, both direct spending on services and indirect investments such as care management, infrastructure, and care coordination. So I think that speaks to one of the lessons learned from the Rhode Island experience, where they talked about how as they had increased their proportion of primary care, that a lot of that went into non-claims based payments that help support the primary care infrastructure. And I think that is very much envisioned to be part of how one could go about spending. It may not be just increasing billing codes, but about maybe providing resources and support to build that infrastructure. And for things that maybe aren't typically being billed for, or and services that aren't don't have billing codes attached to them. And you kind of related to that in the kind of the access and workforce part of this recommendation, we do talk about the continued need to strengthen roles, non-clinical roles such as community health workers and patient navigators, peer support specialists, and recovery coaches as part of improving access.
Excuse me, does the proposed legislation require a certain percentage of increase in spending over, I think it was a 3-year period? What is that? What
So,
is that?
so not to confuse the Health Policy Commission from what's in the, I'm happy to do a separate briefing on the governor's health care bill. The first year would actually set the bench in terms of what the spending is among payers and providers, and then it's 30% aggregate over a 3-year period. Understanding that payers and providers are all at a different place. So we didn't want to be prescriptive in the sense of it's like 10% every year, but, and it's in the aggregate of primary care and behavioral health.
Great. So the next, oh, sorry, Tim.
Sorry. I just wanted to just add my voice to this one, too. I think it's a really important piece. And one of the things that I remember at the cost trends hearing talking to the Rhode Island folks about is the interaction between their price cap with their hitting their benchmark for this, and how we can try to meet that benchmark without a price cap. I think will be a significant challenge that, as we try to figure this out. But that was one piece I remember in that conversation. And to your point, David, adding in and recognizing the need for the workforce development on this entire space, and how if we're moving this, which I think is the right thing to do, what are we doing to prepare the workforce? We already have challenges as it is, and how are we as a state really thinking about as we move towards these goals, that the workforce is prepared and available to provide the care that we know needs to be provided in this setting.
David, one quick follow-up. As we get into a period 9 months from now, 12 months from now, to see whether there has been an increase in aggregate spending, I'd really encourage that we look at procedure-specific, not diagnosis-specific, procedure-specific spending. That's going to be the same kind of telltale on the ambulatory side that a DRG is on the inpatient side. It's not about how much is spent. It's how much is spent on individual procedures that can influence the total spend.
That's a great point. And the last thing I will say on this.
And it's easy to capture.
Yep.
Easy to capture.
The last thing I will just say on this point is that the Center for Health Information Analysis is already moving forward with some proposed data collection modifications such that the Commonwealth will begin to be able to track and understand not just the total proportion, but actually some subcategories of proportion of spend. And that is going to be an ongoing process. I think they're having a listening session
February 12th.
February 12th.
David, do we anticipate that the PIP process down the road could include an examination of this issue?
So the recommendation does include language that talks about potentially holding entities accountable for meeting improvement targets, but doesn't go into the exact specifics of how that might work. I do think that one of the real kind of strengths of this idea and this concept is that it is very aligned with a benchmark. It builds off of the benchmark. It is really talking about, we have a total spending growth target, but underneath that, how can we over time start to have sub-targets, sub-benchmarks? And so it really feels to me, and I will say, other states that are pursuing healthcare cost growth benchmarks are already thinking about additional types of measures that they want to track in addition to kind of total healthcare spending growth. And so I do think this is kind of the next phase of 7 years into a benchmark. How can we even be more sophisticated in how we're thinking about where the spending is going? So the next recommendation here is around ambulatory care. And this is really building off of the work in the cost trends report, showing the increasing importance of outpatient spending in our healthcare system. This outpatient spending was the number one fastest growing category of healthcare services since the HPC has been established. And it reflects market changes, technology changes, and decisions by health systems to invest in these areas. We think that in many ways, moving from inpatient to outpatient is both cost savings, but can also be more convenient for patients and can be high quality. Yet, we are also seeing high growth in spending in this area and high growth in payments and prices in this area. So we believe, as a statement, that we should have some more scrutiny about the dynamics in this particular part of the healthcare system, where I think we have spent a lot of time thinking about inpatient care and the hospital system here to ensure that we have a continued focus and understanding the dynamics on not just hospital outpatient, but the entire ambulatory space, so including within that umbrella urgent care centers and other types of kind of outpatient settings. And as health systems are thinking about investing in and expanding in ambulatory care and outpatient care, that we should, as a Commonwealth, examine what we think the impacts of that will be on cost, quality, and access, both positive and potentially concerning.
As someone who has 5 urgent care centers within a half-mile of my office, it's about time.
Yeah, I was going to say, in the access piece, is just looking at where are these being built is important, but also where they're not being built is just as important as we're talking about access. I think that should be a big part of our review as we look, as this recommendation and others go forward, just where are these happening and why?
Yeah, and I would say, I think in our work in the outpatient research, we feel there is much more deeper to learn and to understand. We did not look at, say, quality in this area, and so I think there's much more to dive into and learn.
David, is the issue here, should we be a little more specific in our recommendation? So it's sort of a little vague as to who should do what and how it should happen, and maybe we should follow it up with something a little more specific to the legislature about what they should do?
I think there are multiple state agencies that have roles to play here, and so I think we were trying to be reflective of the fact that this isn't just an HPC activity. This can be across different regulators and examiners. Certainly, I would note that the governor's bill includes policies around more
The regulatory framework.
For urgent care centers in particular, understanding that they can be licensed in many different ways. The services that they provide can be very different, and causes, I think, both confusion for patients, but also a real lack of oversight and researchers and the public to understand what the dynamics in that particular market are. So I think that's one particular area that, while not explicitly shouted out here in this regulation, is an area that I think is certainly would be helpful and I think add to our ability to understand, specific to that market, how that is changing, who are they serving, what services are they providing, who are they connected to, and right now that information is very, very hard to find.
David, we also have coming in front of us, I think, sometime this year, partner's proposal to build, I think, 4 new ambulatory centers or off-campus centers. That would fall under market oversight, would it not?
So that is likely probably not to be a direct notice to us. We don't know all of the details of what they're proposing, but if it is just an expansion, that will go through the Department of Health's determination of need process. But I will note the HPC is a party of record into that process, and I think there will be, there may be an opportunity for us to appropriately look at the specifics of what that plan is and whether it would be appropriate for us to provide a comment. I think it's premature, candidly, to say at this point.
I'm sorry, I missed that.
To date, nothing's been filed with the Department of Public Health, DON.
But upon filing, we can take a look at it.
The Health Policy Commission would be a party of record. Yep.
So the third recommendation here, again, is really building off of the work from the cost trends report, where we have identified the dynamics and kind of increases in coding, what we call coding intensity, As David noted, there are many reasons and dynamics and trends that are driving this activity, and that there are, certainly some potential positive impacts from having more accurate diagnostic information for clinicians. However, we still have some concerns that there are consequences here that lead to increased spending and that may, in some ways, impair our ability to make effective performance comparisons across organizations. And so our recommendation here is to really be able to better understand what the impacts of this are, and that there may be some specific strategies that payers and providers should take to mitigate some of these impacts, including by upgrading their software and their weighting on a regular basis. We understand that some plans do this regularly, some plans do not, and potentially ways that we offset the spending increases, and finally, are there alternative ways for understanding the risk of a population besides relying on some of this coding work, so that we can have more accurate understanding of the true underlying health and health needs of the populations, and align the resources accordingly to where those health needs are.
David, so I have a slightly stronger reaction to this than mitigation. If you look back at David's slide on page 19, one could say that if we have a coding problem, it should be fixed, and one would expect it to be fixed, and then a ceiling to be reached, and these lines would not be continually rising. This is a game being played, and I wonder, it looks like a game. It doesn't look like there's a real, there certainly isn't an increase in severity. The numbers you calculated, David, it's equivalent to 920,000 more residents with cerebral palsy. This is a pretty big deal. Should we be working with the Attorney General on this a little more closely and talk about this perhaps as an enforcement and an issue of honesty?
I think our investigation and our evidence has shown that this is not a dynamic that is unique to Massachusetts. This is a dynamic that is happening nationally, and there are many reasons that may be driving this. There are laws and rules in place. Payers do auditing of this. So I guess I want to maybe defer to other commissioners on this point. I believe there's, I would recommend a little bit of caution before, and perhaps some more investigation and conversations before going down that road, but I will defer to commissioners.
Can I ask a question related to Don's extremely helpful and important comment? When the plans submit to CHIA now, they're allowed to choose a risk adjustment of their choice as long as it's consistent and so on. And then we get in these problems where their growth on a non-HSA adjustment is 10% and the growth on an HSA adjustment is minus 10%. And like, aren't they doing a great job? Does CHIA have the right to say, here's the risk adjustment tool we want you to use for this submission? Whatever in your own payments you use, that's your own business. But for this, we want you to use this specific risk adjustment.
I would have to get back to you on that. These are, in some cases, proprietary systems. One of the things I would say that we have had some conversations with CHIA about is, is there a way maybe for to receive unadjusted numbers from all of the plans and for CHIA to do essentially a normalization at a kind of an aggregate basis across some of the plans. I think this speaks a little bit to the next recommendation about how this dynamic is impacting our ability to hold entities accountable. But I think it's perhaps a worthy conversation about are there different metrics or different ways of looking at the data beyond just accepting the data as submitted from the health plans. That could provide a good counter example for investigation.
My impression is it's not the health plans that are doing this, it's the providers, because they've invested in Epic, and Epic is very good at this, or whatever other one it is. But they could say, okay, but that's fine, maybe we'll use that for our own systems, but for what we report, maybe the state requires something different.
Not really, but I think that, but yes, there are folks who are developing alternative risk adjustment methodologies that would be less influenced by or less prone to things that a provider could do. And I could imagine, right, I'm not sure how much power CHIA has to say, thou shalt all use this X, but could they or could we run something consistent across all?
I'll tell you what, I think David and Dawn, I don't think they're trying to oversimplify it, but this is an issue. And the fact that I can choose whatever algorithm I like to have a risk-adjusted score, which is basically what I'm graded on, is not the best way to proceed. Whether we recommend a legislative solution to this, or we come up with an algorithm that we can basically test across the board, we should be doing something. Because I think it was one of the commissioners mentioned at one of the meetings at the rate that we in Massachusetts are becoming sicker every single year. We'll all be dead within a decade. So there is something wrong with this, and we should be addressing it.
Do we have the staffing and internal capability to look at the appropriateness of this recoding, what's going on? Can we make some judgments about the propriety or not?
I believe, thank you, commissioners. I think you've all imparted the importance of this particular work moving forward. We have engaged with experts to investigate different risk adjustment methodologies. We've actually had some consultants try to help us navigate this, and I think there's much more work that we could do here. And so I will take that as a charge from this board to make a game plan for this year and how much further we can go and who we can perhaps work with in terms of some experts to help us have a recommendation for action moving forward. Thank you. So the next three recommendations. So the first one here is on pharmaceutical spending. This is not a new recommendation. This has been a recommendation that we have had for many years now, but there is a kind of a new twist or kind of a new element here, which is that part of what we recommended last year was that MassHealth should have a review process, and including a potential referral to the Health Policy Commission. Obviously, that was passed into law last year, so that part of the recommendation has been removed. However, we still think that there is an opportunity to build off of this structure to think about the impact of drugs and the value of drugs across the entire market. And so not just drugs as referred from MassHealth, but perhaps drugs as referred from CHIA that are high cost and that there can be some more oversight and accountability around what is the value of these drugs and is the pricing unreasonable or excessive in relation to that value. The other parts of this recommendation, I think, are actually very consistent with past recommendations around not just more oversight of the pharmaceutical manufacturers, but of the entire supply chain, specifically thinking about pharmacy benefit managers and the role that they play in both pricing and in rebates and the revenue that they collect. And so, as I think I have mentioned before, I think 42 other states, 26, have passed 26 different bills around increasing accountability in the pharmacy benefit manager space. This is a part of the governor's proposal as well, but there are places where we can meet the rest of the country in terms of increasing transparency, again, not just on manufacturers, but across the entire chain. Another part of this recommendation, beyond kind of government oversight and transparency, is, are there other ways that payers and providers can work together, payers, providers, and manufacturers can work together to improve value? And so continue to support the evolution of value-based contracts or outcome-based contracts in pharmaceuticals, monitoring prescribing patterns, and perhaps putting reports back to clinicians and prescribers, and developing protocols around when to use, what is the best value drug for certain populations, and how we can make sure that patients have access and can afford the high value drugs that will truly make a difference. And thinking here, of course, around insulin drugs, a very high value drug, how do we ensure that there's access and affordability there? So a little bit of mix of some repeats, but also some new text here. The middle one here is a new recommendation around accountability under the cost growth benchmark. And as we have discussed multiple times through the PIPS process, which I think we maintain has been an incredibly important accountability tool, a sentinel tool that sends an important message to every single individual entity, provider, and health plan in the Commonwealth that they are held accountable to the healthcare cost growth benchmark. And through that confidential review, I think we have been able to influence market behavior in significant ways. However, we also recognize that there are some limitations to the current process as it stands. Right now, only managing physician organizations are referred under this process based on their attributed HMO patients. So, for example, an individual hospital would never be referred as part of this process. In addition, the trigger that CHIA relies on is health status adjusted total medical expenditures. As discussed before, we think health adjustment is really important, and we think it should always continue to be a factor, but perhaps other factors should also be a part of that referral process, not just triggered on the health status adjustment. And that perhaps there are ways to even hold entities accountable for the spending that they contribute above benchmark. And so these are, I think, suggestions intended to inform the legislative debate moving forward, and ways that will maintain our leadership as a state in terms of our oversight and the strength of our benchmark and our review process, and strengthen the HPC's ability to really use this tool effectively. The final new one here is also a little bit of a repeat, but is really, again, kind of a value statement around the importance of including the employer community in these healthcare cost conversations. We think that employers have an incredible voice as a major purchaser of healthcare to help influence both the plan options that are available, access to care for their employees, educating employees, and engaging employees. And so I want to have a statement here around the importance of creating collaborations among business community and employers, and their ability to help make high-value plans available to their employees. And a part of this also is that plans should help design those types of plans such that they can be available to employers, and that employers can offer some choice to their employees. We have seen through the connector experience that choice in shopping is a really powerful way to drive high-value choices. And the connector continues to be, for those eligible small businesses, one of the very best mechanisms to get really affordable health care, second lowest in the country, and so continue to want to sing their praises as an option for many small businesses.
So David, I totally support this recommendation. I just have a question. The last sentence says policymakers should take action to broaden employer access. Do you have a specific recommendation there relative to what policymakers should do?
So there are some provisions within the governor's bill, but I'm sure there are other legislative proposals that talk around ensuring that plans are creating different types of innovative products and making those available to employers across the Commonwealth. And so that is envisioned within there. And I think there's a few other pieces there that talk about mainly requirements on the health plans to make more choice available.
So as we speak, Actually, the governor signed an executive order when he filed the healthcare bill that created a merged market commission.
Oh, right.
That brought
Yep.
together employers, many of the voices of insurance. I should be there, but I'm here with all of you. Actually, Lauren Peters is representing me quite well there. And I think that report's due, I think, April. And that might be actually good information to have. We'll make sure that the HPC gets to be a public document anyway, to get it to help inform this. And there are some, I'm just sort of saying ditto to all these in the governor's healthcare bill. Thank you so much, David. And there are things in the governor's healthcare bill, but there's a number of legislative proposals around employer insurance opportunities.
And thank you, Madam Secretary. And I should say, I'm referencing the governor's bill here, but there are many other
yeah,
legislative
absolutely.
proposals and
Yep,
initiatives.
yep.
And so in some of these recommendations, I think we are recommending kind of strategies and principles and values rather than not a specific proposal or a specific bill, respecting the legislative process and the work that's still going on with the merged market.
My
study.
comment was really a tease. I want to be clear. This is the HPC is not endorsing the governor's bill. We would never ask the HPC to endorse the governor's bill. It's just nice to see shared themes, priorities.
Can I just
Coincidence.
ask a follow-up? So I think there was a project earlier in the year, Rick, that the business community launched of doing just this around engagement or with the broader community, reducing costs. Like ER utilization was one of the goals. I'm just wondering if there's a report back from that group around some of the work that's been happening. I think HPC was supportive with some technical assistance or whatnot. Is there going to be a report back? It speaks directly to this recommendation, so I'm wondering what has been done and what is some of the outcomes of that work?
Yeah. There's been some tremendous work being done over the last year with this coalition. It's called the Massachusetts Employer Health Coalition, and specifically reducing on strategies to reduce avoidable emergency department utilization. I think the short answer, Tim, is it's a longer answer, but I do know that coalition is expecting and planning an event, a public event this spring, where they will talk about the work that's been done, some of the successes had, and what the plan is for the future. So I think I'm happy to report back to you at a future meeting, but I think there will be more coming out very soon on that front.
Is that the April 29th one?
I don't think it's been scheduled.
Employer. Okay.
All right, so that concludes kind of some of the newer recommendations. I will not belabor the revised and refreshed recommendations. These are very consistent and in many cases just a reflection of the fact that the work continues. Certainly administrative complexity, this has been a huge project for the HPC over the last year. We think there is much more work to be done. This is a top priority work stream for us. We're going to continue this work. Facility fees and out-of-network billing, we think that there are very reasonable policies that can be put in place, laws that do need to be passed to protect patients in both of these areas. Many other states have passed laws in these areas, and we think that Massachusetts should follow their lead. On the next page, again, kind of three ones that are not new. We continue to believe that alternative payment methods are an important mechanism for driving efficiency and value in the system. The stagnation of APMs has been a concern, especially in the commercial space, not in the mass health space. Mass health is now a leader. But we hear from providers every day that the continued division between fee-for-service and risk-based contracts just creates an inconsistency in their ability to plan and invest in the types of care coordination and care management structures that would be most effective at helping patients and reduce costs. So we continue to recommend continued alignment, movement towards capitation type models, and that the self-insured market should also be encouraged to adopt risk contracts. A continued value statement around ensuring that we are looking at inequities and disparities in all of our work, and consistent with some of our work that we are doing with the Department of Public Health in terms of investing in new collaboratives that seek to address upstream social determinants of health continues to be a priority. Through all of our investing, we want to be able to disseminate the learnings. We think that there is a culture of learning and continuous quality improvement that the Commonwealth can continue to play a role in. Final three, low value care. We document in this report the continued provision of care that clinicians and experts agree does not provide value to patients, and in some cases provides harm, and increases spending both for the total healthcare system as well as for patients, and that there are strategies that can be pursued to reduce the provision of so-called low value care. Provider price variation, as noted with the work on the outpatient payments, continues to be an area that deserves attention. And then finally, I think a recommendation that we put last to kind of span across everything as a true capstone to these recommendations, that to keep in mind the real affordability challenges that individuals and businesses are facing in the Commonwealth. And that through all of our work, we should think about how does this actually translate into making healthcare more affordable for our residents, especially lower and middle income residents who bear, and smaller businesses who bear a disproportionate burden of healthcare costs in the Commonwealth. All right.
David, I'm sorry.
Actually, let me go to Don, and then I'll come back to you, Chris.
Thanks, Marty. First, wow, what a ambitious set of things to work on. I wish you well. That's all important. I just want to make a couple comments on 14 and 15. Starting with 15, I do think it's really important. I just want to underline it, to keep an eye on the pocketbooks of the people who live here. And from what David's showing us, no matter what we celebrate about hitting a 3.1% benchmark, that's not happening to the consumers. And I know these aren't in rank order, but that's crucial. Back to provider price variation. So look, since our charge is focused so much on rate of rise, it's easy to take our eyes off the ball of the starting places. And they're really problematic. Partners especially, of course, but not alone. And so I don't know what to say or do about this. And I know we've been through the cycle now of the new legislative committee that was set up. But can we spend some time at some point talking maybe a little more open-mindedly about what we might do to get on top of that? Because it's pretty dramatic what's going on with provider price variation.
That's where I was going. I think CMS has promulgated new rules that are being resisted by both payers and providers. It seems to me like it's the right thing to do. I'd welcome more conversation about it.
I think that sounds great, and I would note one of our upcoming publications that we're working on right now is what we're calling kind of a 5-year market retrospective in terms of how certain market dynamics have changed since the HPC has been established. So we have a long trend here, and one of the areas of that examination is price variation and the variation. So we'll have some new refresh data. I can tell you the conclusion now. It has not gotten any better since the passage since the beginning of the decade.
Are we restricted to applying our benchmark evenly across all providers, or could we begin to come up with a different model in which high-cost providers have to achieve a much more stringent benchmark than low-cost providers, it all averaging out to the state? Do we have the authority to do that?
So, not under the current statute. The current statute has some restrictions around what the trigger is into our referral process. That is one of the reasons we are recommending to remove some of those restrictions so that we can have perhaps some flexibility in having a broader community conversation about what might be maybe multiple triggers or adjusted triggers. I will say, though, as you all know, when we do receive a referral, and we are examining a certain entity, one of the things that is a factor is what is their prices relative to other providers. And so, a high growth provider with a very high price may be maybe more concerning than a very low price provider that has growth. So it is a factor that we look at once we get to that review stage.
I am aware of the time crunch that we're under. I just also want to say, great report. I think these new recommendations, I think, are not only timely, but significant to the work of the commission. I want to congratulate David and his staff for the work. But we also need a motion to officially release the report.
So moved.
Is there a second?
Second.
And we will do a roll call vote so we can have Stuart participate as well. So Cassandra.
Aye.
Aye.
Yep. Aye.
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 Stuart?
Yes, I say aye, very much so. And let me just say, with respect to the coding, I would suggest that the staff get in touch with the people in Washington at MedPAC, because this coding issue has been going on since the 1980s, and I know the feds have been working on it, as well as some of the big insurance companies, to try to at least adjust for it. So I would suggest we work with them. But thank you all, this was great.
Great recommendation, Stuart. Thank you. Okay, so the motion passes. We will now move to discussion of the drug pricing review and the final regulations. And David and Lois and Kate.
Great. So I'm going to be joined here at the table by Lois Johnson, our general counsel, Kate Scarborough-Mills, our director of market oversight, and Celia Siegel, who is our associate director for pharmaceutical pricing and policy. Before we dive into walking through the recommended modifications to the regulation, I do want to just say a few opening framing remarks. I want to publicly acknowledge all of the stakeholders that attended the public hearing that we held on this proposed regulation in December and/or provided written comment. I think many of them are in the room here today. And as you'll see, as Lois will show you from who did testify or provide written comment, it really is a broad cross-section of stakeholders, from pharmaceutical industry representatives to consumer advocates to patient groups, including those representing disabled individuals, health plans, and faith and justice organizations. To all of those that submitted comment, we examined and very carefully considered your suggestions for modifications to improve the regulation. And as we'll walk through, we are recommending a number of responsive changes that we believe will enhance the process in many ways while still being fully consistent with our statutory authority and responsibility. I also do want to acknowledge our colleagues at UHHS and Mass Health with whom we work to appropriately align our processes and definitions while still respecting and understanding our different independent roles in this process. I want to thank you, commissioners, for your feedback and input into this. It's been invaluable. And I just want to say you have all really thoughtfully engaged with these new responsibilities, I think consistent with our approach to other market oversight work upon which these new responsibilities are built. Throughout all of the conversations and comments we received, I appreciated that while there were certainly areas of disagreement, there were also broad areas of agreement, especially around the common values of enhancing access, innovation, and affordability for prescription drugs. And so today is one step in this process, but far from the last. And we really look forward to continuing to work together collaboratively, creatively, inclusively, and transparently to advance this work and to achieve those shared values and goals. So with that as an introduction, I will turn it over to Lois, who will walk through the comments, our process, the comments received, and our proposed modifications to the regulation.
Thank you, David. Good afternoon, commissioners. And this slide shows the new statutory framework that governs both the Health Policy Commission and the Executive Office for their respective drug pricing review processes. And before discussing the changes to the proposed regulation, I just want to quickly provide an overview of the two processes. So the new law passed in July authorizes the Executive Office, which operates the Mass Health Program, to directly negotiate with drug manufacturers for supplemental rebates for the Mass Health Program, in addition to rebates already mandated by federal law. If those negotiations are unsuccessful, then for certain high-cost drugs, Mass Health may identify a proposed value of the drug and gather data and information and potentially hold a public hearing. And the statute does define high-cost drugs, which for an individual utilizer, the cost would be annually post-rebate to Mass Health of $25,000, or in the aggregate, a cost post-rebate of $10 million or more. So based on the information and comments received through that process, Mass Health then updates its proposed value as appropriate and solicits further negotiations with the manufacturer. If those subsequent negotiations are still unsuccessful and don't result in a supplemental rebate agreement, then Mass Health may refer the manufacturer to the Health Policy Commission. So the Health Policy Commission's process is only triggered by a referral from Mass Health. If a manufacturer is referred, the HPC is then authorized to collect information related to the manufacturer's pricing of the drug. Based on the manufacturer's submissions and other information, the HPC may identify a proposed value of the drug, a proposed supplemental rebate, and then in a two-step process may ultimately determine whether the manufacturer's pricing is unreasonable or excessive in relation to that proposed value. And so that two-step process is shown here to the right of the slide, which involves first a determination whether the pricing is potentially unreasonable or excessive, and that's another process point that triggers additional review of information from the manufacturer and other stakeholders. And then second, the HPC would issue a final determination on whether the pricing is unreasonable or excessive in relation to that proposed value. So that's the overall framework for both processes. And as you recall, following the enactment of the law, HPC spent several months in its regulatory development process, including, as David mentioned, coordinating closely with Mass Health and their team, and researching other drug review processes and price transparency laws used in other states, among other areas of research. The board, as you recall, approved issuance of a proposed regulation on November 20th. Public hearing was then held on December 13th, where we heard in-person testimony from 5 stakeholders. We then received 9 written comments before the close of the comment period, and actually staff personally met with all of the individual groups that submitted written comment. We also released at that time a draft standard reporting form, which is called for in the statute. We expect to continue working with stakeholders and manufacturers in particular over the coming weeks on that form to finalize it. But that brings me to an important process note, which is that a difference between the regulation, the standard reporting form, and the framework. So the regulation that you are asked to finalize today is really intended to lay out the HPC's process, the procedures for conducting the drug pricing reviews, identifying the categories of information the HPC will ask for, and the factors for consideration in conducting its reviews. It isn't intended to and does not lay out in detail the framework or methodology for how the HPC will assess value, evaluate that evidence, and make pricing determinations. That framework is to the right, described on the right-hand side of the slide. That's something that we anticipate working with commissioners and other stakeholders over the coming months, really to develop and refine, and believe that it would be sort of a living document and to be informed as we go through these processes. that is very similar and consistent with how we have approached other HPC market oversight activities, including the cost to market impact review process and the performance improvement process, which you're going to be talking about later today. And then finally, in the middle, the standard reporting form is also, that's not part of this regulation. That's intended to be a sub-regulatory document, although topics of categories of information are referenced in the regulation. The form will be finalized with the manufacturers and other stakeholder input regarding exactly how things will be submitted to the Health Policy Commission, the template, the details about that information. That too will be posted on the HPC's website, similar to the MCN form and the data submission manual that we use in our RPO program. This slide, for your reference, lists all of the stakeholder groups. As David said, a wide range of groups submitted comment to us. And for purposes of today's meeting, I'm going to really just focus in on 4 main areas of comment, and in particular those where we do recommend making changes to the proposed regulation. So the first large bucket of information is around the information to be submitted by manufacturers to the Health Policy Commission. We received comments in particular from the pharmaceutical industry groups around concerns that the data requested were confidential and proprietary. And they requested additional safeguards around keeping that information confidential. And it is true that the statute does contemplate that the HPC will obtain confidential and proprietary information in this process, in particular pricing information. And for that reason, the law exempts that information from disclosure under the Public Records Law and goes further to require that HPC keep that information confidential. The HPC, fortunately, has extensive experience doing just that in our other market oversight processes, where in our CMIR context and the PIP context, we do obtain confidential information and don't disclose it publicly, but we use it for our work. We have instituted security practices internally to ensure that information is safeguarded. For example, limiting access to that information to key personnel, use of passwords and encrypted media around transmission and the like, and of course rolling down to any contractors those security requirements. So to address concerns about confidentiality, staff recommends adding language to the regulation, specifically requiring the HPC to develop protocols to protect the confidentiality of records received in this process. And that's something that we're in the process of developing already. It's consistent with what we do, and we explain this in our in-person meeting with the manufacturers as well. Next, in order to understand what constitutes a complete response to be in compliance, industry groups sought clarification of one of the requirements in the proposed regulations to submit an analysis of value. So staff recommends clarifying that language so that it is not so vague, so that the manufacturer may provide its own estimation of the value of the drug, such as existing analyses to support such estimation. Must provide, yes. Industry groups generally did object to the pricing and financial information required on the standard reporting form on the grounds that it is sensitive and confidential, but also based on its relevance and to the HPC's review and the availability in the requested formats that were in the draft form. The categories of pricing and financial information requested are consistent with the statutory charge for the HPC to identify. Oh, excuse me. Did I miss a? Thank you for pointing that out. One of the other important changes we made is to ensure that if we do update the standard reporting form, the HPC will provide advance notice to manufacturers, and that's consistent with this being not a regulatory document, but a sub-regulatory document that we would work over time to refine.
Sorry.
Thank you. Great. So on to the pricing and financial information. Again, the categories of information around prices and financial information are consistent with the statutory charge of the HPC to identify a proposed value of a referred drug and a determination about whether or not that pricing is unreasonable or excessive in relation to that value. The HPC has broad authority to require information from manufacturers under the statute and broad discretion to determine what factors may be relevant to its review. The law explicitly authorized the HPC to obtain that pricing data. The framework references international prices, for example, and financial information both on the aggregate and per drug basis are required in other value assessments that we're aware of, including by other review bodies such as New York. While we don't recommend limiting the categories of information here, we do recommend amending the regulation in several places to address concerns about the availability or feasibility of submitting certain information, allowing more flexibility in the standard reporting form so that staff can work with manufacturers and stakeholders on the format of the information to be submitted on the form.
Lois, can I ask you a question on that particular part? When we do our CMIRs, we presumably get information in different formats, and has that worked out well? Like, do we find that process works well in that context?
I'll let Kate chime in, but I will say that over time we have developed effectively a standard template when we conduct a cost of market impact review, both for payers and providers, but that can get tweaked over time, and I'll let Kate.
Yes, that's absolutely correct. And so similar to what we've done in cost of market impact reviews, our expectation here is to provide a standard way of collecting the information from all manufacturers, but to engage with any manufacturer under review to understand exactly what data they have, in which format they keep it internally, and on what timeline they can provide it. We've, in the past, in our CMIR authority, been very flexible when folks don't keep things in exactly the way that we expected. You know, for example, we may ask for something on a calendar year, and the way that they keep their records is on a fiscal year, and it doesn't actually, at the end of the day, matter very much to our analyses. We've always been flexible about allowing things to be reported in the way that really the entity can provide it most easily to us.
And if I recall, we've never, to best of my recollection, we've never fined an organization.
That's correct.
For not submitting information in exactly some format that we've specified or something. Is that correct?
That's correct. To date, our process has been very collaborative with providers and payers, both in the cost of market impact review process and in the MCN process, actually, as well as in the performance improvement plan review process, that we've been able to work very collaboratively to get information on a reasonable timeline and in a reasonable format for everybody involved.
Right, and very consistent. We have never imposed a fine for noncompliance. The language here on the fine, the penalties, is very similar, if not identical, to the fine language in our cost of market impact reviews. Both statutes require that fines are a last resort, and it's really about, effectively willful noncompliance. And that leads nicely into this next point, which is around the 30-day timeline. And as Kate mentioned, timelines and working with stakeholders is something that we do in the cost of market impact and other processes. Industry groups were concerned about the 30 days which the regulation provides to submit that information. So likewise, we do contemplate agreements to extend due dates and recommend clarifying that language even more to say that another time frame for submission of information may be agreed upon with the manufacturers and the executive director. So we had a number of comments around the public engagement in this process, and so are recommending a number of changes in this area. Consumer and disability advocates, for example, as well as industry groups, suggested that the HPC should have a clear process for considering input from stakeholders, including patients, caregivers, and clinical experts in identifying a proposed value of the drug. So based on these comments, staff recommends several changes to enhance the transparency and allows for greater engagement in that review process. First, adding a new section which specifies that the HPC shall post a notice on its website following the notice to a manufacturer that they're under review. So that sort of gives everybody awareness that a drug is being reviewed by the HPC. Second, explicitly allowing interested stakeholders to provide data and information that they consider pertinent to the HPC's review at any time during our process. And importantly, the last piece is stating that the HPC will consider that information in its identification of a proposed value of a drug or its pricing determination. Relatedly, patient and disability advocates requested greater transparency regarding the basis for the HPC's determination that a referred manufacturer's pricing is potentially unreasonable or excessive in relation to proposed value, as well as the sources of information that are used. And so our recommendation here is to add a new provision directing the HPC to publicly post a summary of its rationale, as well as a list of any third-party cost-effectiveness analyses relied upon. And that can be for consideration of all stakeholders. Consumer groups in this, the vein of promoting greater transparency, strongly supported the proposed regulations requirement that following a determination of that the pricing of a drug is unreasonable or excessive, the HPC post publicly the proposed value of a drug. In contrast, industry representatives opposed publication of that proposed value. So given those divergent views, but consistent with the overall transparency goals of this review process, no change is recommended here regarding the publication of the HPC's proposed value of a drug. And we understand that's consistent with Mass Health's approach, which is that they would publish a proposed target value. Another key area of comment was regarding the factors in identifying a proposed value of the drug, and we received several comments here. First, around clinical effectiveness, that term. Disability advocates requested that the HPC consider not only clinical efficacy, which is the language in the statute, which regards how the drug performs in research conditions, but also include clinical effectiveness, which is how well it performs under real-world conditions. And we think that's a helpful distinction and good clarification, so we are recommending updating the regulation with language to include clinical efficacy, effectiveness, and outcomes in the information requested not only in the standard reporting form, but also in the factors used by HPC in identifying a proposed value. Disability advocates and industry group also requested that the HPC consider several additional factors in its assessment of the drug's value, including outcomes important to patients and families. And here, recognizing it's appropriate and important to include such considerations, we do recommend several changes here so that the HPC in its review may consider the extent to which the drug addresses unmet medical need or impacts patient subpopulations, the likelihood that the drug will reduce the need for other care or reduce caregiver burden or enhance quality of life. Also, adding in the characteristics of the drug, including the means and setting of administration, dosing frequency, duration of therapy, side effects, interactions and contraindications, and potential for misuse or abuse. So all of those factors we thought were really helpful to include as among the many factors for consideration by the Commission. In addition, industry groups and payers suggested that in identifying a proposed value for the drug, the HPC consider therapeutic equivalents rather than just pharmaceutical equivalents of a drug, and we think that is a helpful change, broadening the consideration, so we're replacing pharmaceutical with therapeutic. Concerning the third-party analyses that may be considered by the Health Policy Commission, disability advocates and industry groups raise concerns about the use of analyses by independent third parties, recommending a ban on the use of any cost-effectiveness analyses that use quality-adjusted life years, or QALYs, in identifying the proposed value of a drug. The QALY is a widely used metric in health technology assessments, both nationally and internationally. The statute does explicitly authorize the use of independent third-party analyses. It doesn't explicitly prohibit the consideration of those that use QALYs, but it does recognize and acknowledge some of the limitations there by requiring transparency about their methodologies and assumptions. And so as the Commission is building this process to carry out its statutory charge, staff's recommendation is not to foreclose the Commission's ability to consider all information and all analyses that may be available in its value assessment. Rather, staff recommends revising the language in the regulation to require that the Commission affirmatively consider the methodologies and models underlying any such analyses, including any assumptions or limitations of the research findings in the context of the results, and any outcomes of affected subpopulations that utilize the drug, if applicable. Finally, disability advocates expressed some concern that in identifying a proposed value for a drug in this context, it could negatively impact patient access. The HPC's review will by necessity be at a population rather than an individual patient level, and nothing in the statute or proposed regulation alters existing frameworks for regulating health plan coverage or utilization management determinations, or impair any existing patient rights. And consistent with that understanding, and to go some way to address this concern, the recommendation here is to add language clarifying that any determination of value of a drug in this process is not intended to be a determination of value of the drug for any individual patient. So those are the major areas where we are recommending addressing and being responsive to comments. And just want to note, we are making some technical edits for clarification and to streamline and to be fully consistent with the Mass Health regulation.
Thank you, Lois. I appreciate the thoroughness and thoughtfulness that you put into listening to all of the concerns, both raised by the advocacy community as well as the industry itself. Let me open it up for questions, and then we can move towards a vote.
Lois, back to your slide 40, page 44, where you're showing the HPC process. Just remind me, after the last box, within 60 days, HPC issues its termination. What happens then? I mean, is there consequence to ignoring us? Can the manufacturer simply not supply the drug? Is there what happens?
Thanks for bringing up that point, but that really is the end of the HPC process. The process ends not dissimilar to our cost and market impact review process with a public determination, and that determination may be considered by other parties, but there's no explicit direction of that in the statute. So the process ends. It's a transparency process.
So it's not that the drug will, of course, have to be available in the Mass Health program. It means that Mass Health was not able to negotiate a supplemental rebate.
I just want to pick up on two quick aspects of this. One is, I'd raised the earlier question because of the concern which seemed to run through this, that what we were trying to do is make money for the Commonwealth by imposing a bunch of fines on people, which has never been our intention in anything, and I wanted to assure myself that that's not our intention in this process either. And then the question is the substantive question about, can this be done? You know, that is, and it seems to me that increasingly around the world, the answer is yes, it can be done. That is, it's done by public agencies in the UK, it's done in Australia, it's done in any number of other countries, it's done by a lot of private insurers in the US. There are various different methodologies that are used, as you note, but it's something that like this is not a novel idea for which we're trying to, build the airplane as we fly it. Some of the things we've had to do are quite novel that way. This is not novel that way. It's just trying to bring these together in some coherent way and make a recommendation to the Commonwealth about how that happens. So I think we're on, it's never going to be uncontroversial, but we're on reasonably solid ground in the sense that there is a lot of literature there. And so I appreciate sort of going through and getting rid of all the underbrush about what if I don't know the exact name in 5C of the form, and are they going to kill me as a result of that? Because that isn't certainly where I am, and that's not where we are. And just to get into okay, how do we take these methods that are widely used and generally accepted and use that to help the Commonwealth in some circumstance?
Others?
Do you want to do the regs first, then I'll make my comment.
Well, let me just see if there are any other comments for Lois before we get into the motion. Cassandra?
Just a question on page 46, Lois, where you've laid out the framework, how we will move forward determining how to go about evaluating drug prices. Has New York been public in its process when it has actually reached that stage of the process, and is that something that we could draw from?
We have, in fact, been in contact with folks from from New York who've been doing that review in their Medicaid program, and their process was, in fact, public. And I'm going to defer to my expert colleagues here to say more.
Yes, and so there are aspects of their process that have been public. There are other aspects that have been confidential, and so we are working closely to try to understand both from our state colleagues as well as from experts and international colleagues how best to do this. And I would say that each of those processes has different rules about what parts are public and what parts are confidential, and happy to kind of go into that in more depth offline. But there are key parts in particular of the New York process that are quite public.
Great. Thank you.
Chris?
Yeah, so a couple of questions, but beginning with a comment that the obvious complexity here is we're running up against trying to determine value in an age of gene therapies and precision medicine, and we do have silver bullets now, and they're very expensive, and it's only going to increase. It's going to increase dramatically. I mean, we didn't even we hadn't decoded 18 years ago, and now we can do SNPs for $500. So there's going to be a lot more of this, and I guess we all know it. My question is, on the last page, 53, on that this doesn't apply for individual patients. So how does that work? Let's say there is one kid who has a form of blindness which is cured by Spark's new drug, Luxturna, which was approved with reimbursement of $1.2 million, I think, roughly. Does that mean that just sails right through? I think the answer is yes, if it's in your formulary, right? And right?
So, let me give you a little perspective here.
Yeah.
Since
And Mary Lou, if I could ask, as part of the perspective, is there any opportunity to resubmit a waiver to attempt to be able to limit formulary?
So let me take these one at a time. So first of all, we appreciate the Health Policy Commission working closely with Mass Health. This is a version of the authority the governor asked in his budget last year to allow Mass Health to engage in direct negotiations with drug manufacturers. And we're now implementing the second half, if you would, the regulatory framework for this. So since receiving the authority to engage in direct negotiations, Mass Health has finalized agreements with 6 manufacturers on 12 drugs for an approximate net savings of $13 million and gross rebates over and above the traditional Mass Health rebates you would get, Medicaid rebates, of $34 million to the Commonwealth. We have 14 more in various stages of negotiation, and some of which will be finalized soon. 4 of the drugs would have tripped the threshold for referral to the Health Policy Commission. Some of them are are orphan drugs, to use an example. Here's where the authority has really worked. So after the budget passed, we actually had several drug manufacturers knock on our door to start negotiations. I think out of concern, like get early in to negotiate rather than wait to see what the regulatory framework would look like. So I want to be very clear, though, to everyone who is thinking that this is restricting drugs in the Mass Health program. There is no restricting drugs on the Mass Health program. This is about increasing value to the taxpayers of the Commonwealth to try to lower the costs beyond what would be the traditional Medicaid supplemental payment. So if there is a child or anybody on Mass Health who has some very complicated illness that requires, obviously, whatever it is, right? Zolgensma, think of the high-cost drugs. They have access to those drugs. This is literally just lowering the cost to the citizens of the Commonwealth. That's one. 2, we believe that this is a good state way of ensuring universal access to drugs on the Medicaid program and bringing down costs. We explored in the past opportunities to work with CMS on perhaps a formulary, and those were not successful. And we actually think this is a more successful way to manage the Mass Health program.
Do any states have permission to restrict formularies in Medicaid?
Oh. Depends on, there are some states that are exploring with the federal government restrictive formularies, and the recent guidance that's come out from CMS would allow states, if they went block granting, one of the opportunities in that the CMS guidance that just came out was states that were interested in block granting would have opportunities to explore formularies. And that's not something that we would propose in Massachusetts.
And are the successful negotiations, have they included any value-based contracts?
So in Massachusetts, so we also received authority from CMS last year to do value-based contracts, and 2 of them are value-based payment systems. Yep, including Zolgensma.
So that's great. But I want to go back to the individual because of the regulatory question. It sounds like we're going to amend it to say that individuals are excluded?
I think
I'm not sure what the recommendation is.
Some of the commenters raised concerns about this process, which, as we've described, it's really going to be conducted at a population level.
Right.
Nothing about our review would really consider the ability of individual patients in Mass Health or in any other health plan to access a pharmaceutical product. It's really kind of just a signal, just to underline what we understand to be true given the statutory framework. Individuals, of course, in any health plan would have access to appeal any medical necessity determination, and nothing in our process, as the Secretary indicated, will limit coverage in Mass Health, nor is there any, nor would any other commercial health plan be compelled to make coverage decisions based on our value determination.
Yeah. So I think I understand. If there's only one individual, and you're adding them all up, it's 1, right? You've aggregated, and you're still down to 1.
I read it differently. I think this is just a message that you shouldn't use this information for clinical decisions for any patient.
Right.
That's correct. Thank you. That's helpful.
Okay.
Okay. I need a motion to approve the final regulations as drafted.
So would we want to change the language to the language you just used for this last one? Or no? Just say that this is not meant to be a clinical determination as to need in a particular patient. Or will we get in a situation, I'm just worried we'll get in a situation where there's personalized medicine and therefore the claim will be we can't use this process because it would be unique for each person. Like I wouldn't want that claim.
Our thought in drafting the language, it's sort of a high, broad level to think about value, was that it sort of captures sort of a broader concept and doesn't get into sort of clinical or medical necessity determinations. And we've actually previewed this concept with some of the disability community, and it seems like that this is a welcome statement in the reg.
So again, I need a motion to approve the regulations as drafted, which I think we all received the final copy in our packet. Barbara, is there a second?
Second.
Don? Any further comments before we take a vote? Okay, this also requires a roll call. Cassandra?
Aye.
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 Stuart?
I support, thank you.
Thank you. Okay, good work. Thank you. We now move on to our executive director's report. David?
Quickest executive director's report ever. We have, our next meeting will be our benchmark hearing. It's going to be Wednesday, March 11th at noon at Gardner Auditorium. Hope to see you there. Here is a slide for the public summarizing some of our upcoming publications, including our cost trends report and chart pack, which will be available on our website like now, as well as the revised regulation that we just approved. Our grant program that we are working on with DPH and Mass Health, we are in the process of soliciting applications. We had a webinar in January with close to 200 people signed up expressing interest in this program. So just a reminder to everyone in the public, we extended the deadline a few days. The deadline is now for proposals February 26th. And now I think we are prepared to move into executive session. And so for the executive session, we're going to be discussing the referred list of confidential entities from CHIA based on their performance in the 2016 to 2017 period. This is our first meeting on this, this list, and do expect to be back to the board later this year with further work on this topic. I will let people know that the executive summary of the cost trends report is also available at the door, but at this point we will be moving into an executive session. So thank you, members of the public. We will not be returning to the public session after the executive session. So I do think we need a vote to move into executive session.
All right, move in a second. Second.
I think we need a roll call.
Roll call.
Yep.
Cassandra?
Aye.
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 Stuart?
Aye.
Great. Thank you all for your participation today, and we'll take a 5-minute break while we